Dear Pure Urology Facebook viewers, good evening one and all. Today we are discussing about female urethral stenosis, buccal mucosal graft urethroplasty. Today's speaker is Dr. Soundarya, who has done MCH from Madras Medical College and concentrating on female urology, urodynamic study and thulium fiber laser. These are three areas of our interest. Because she is the consultant at Preeti Urology and Kidney Hospital, I already know her for last 2 years. Very hardworking, sincere and interested in clinical research and writing papers. With this I officially introduce her and then hand over the program to Dr. Soundarya. So today talk is female buccal mucosal graft urethroplasty. Dr. Soundarya is MCH Urology from Madras Medical College. She is MBBS from Kanyakumari Medical College and MS from Stanley Medical College from Madras. All the three are primarily prestigious government institutes. She did fellowship in endourology and laparoscopy at Preeti Hospital under the mentorship of Chandramohan. Consultant urologist now for last 2 years. Presented papers in national conferences, published articles in national, international right from her PG days. Being very studious and sincere student, I hope she will justify. She is involved in all the surgeries of buccal mucosal urethroplasty along with our senior urologist Dr. P. Ramakrishna. Both have done more than 12 cases, I think. With this experience, being the new subject and keen interest and participating in various female urology conferences also, I hand over the program to Dr. Soundarya. Dr. Soundarya, over to you.
Good evening, one and all. At the outset, I would like to thank my mentor, Dr. Chandramohan sir, for giving me this opportunity. I also would like to thank Dr. Ramakrishna sir, because of whom I am able to go about and treat such patients with a female urethral stricture. And it is because of his guidance we are able to do such cases successfully. So thank you, sir. I am starting off with my presentation. Female buccal mucosal graft urethroplasty. So, coming to the female urethral stricture, this urethral stricture disease is very much underdiagnosed in women because of the very varied presentation, and there are no definite guidelines for investigation or treatment. And even when it is diagnosed, urethral dilatation is the procedure which is still very commonly performed. What is the definition for stricture urethra? A fixed anatomical narrowing of the urethra that will not accommodate any instrumentation without disruption of the urethral mucosal lining was said by Smith et al. Osman has defined as failure of catheterization, urethral calibration, visual inspection, endoscopy or radiography as the definition for stricture. So coming to the incidence, because of either whether it is underreported or overtreated, the exact incidence is not known. From the available literature, it says 4 to 13% causes of the bladder outlet obstruction is because of the urethral stricture. What are the causes? It could be idiopathic, iatrogenic, traumatic, or inflammatory. So when a patient comes to us, the initial assessment which is done is the evaluation of symptoms, mainly with the IPSS score, and a complete clinical examination. Complete pelvic examination is done. Presence of any lichen sclerosis, cystocele, associated vaginal scars, and whether the vaginal epithelium is good. So these are the things to be assessed. And the investigations to be done are, as usual, we start with ultrasound KUB with post-void residual urine. and followed in the ultrasound KUB, we look for the bladder wall thickening, post-void residue, and presence of hydrourethral nephrosis. This is the typical pattern in uroflow which we get. We all know the box pattern with a fixed flow. The next is the urodynamic study. Here we look for any detrus or overactivity, associated incontinence, the presence of compliance, whether the compliance is preserved or not, and the voiding pressures, detrusor pressures. So if the PDET, that is the detrusor pressure at Q max, is more than 50, with the voiding Q max less than 12 ml per second. So these are some of the urodynamic criteria defined to diagnose stricture. So as we can see in this picture, the PDET at peak flow is 144 centimeters, and the bladder contractility index is also very high, it is 169. So it is typical of bladder outlet obstruction. The next investigation to be done is the MCUG. This gives an assessment of the site and the length. As we can see in this picture, the pre-stenotic dilatation is present and the bladder wall outline, whether any tuberculations, and the exact site and length can be assessed. The MRI pelvis we don't do routinely, but in special cases, it can be helpful to assess the periurethral fibrosis or any presence of diverticulum. So this is the preoperative urethroscopy we do. We do either with a 7.5 French nephroscope or a 6 by 7.5 French uretroscope. This is the typical appearance of the urethral narrowing, and we can see the bladder trabeculated and thickened as well because of chronic outlet obstruction. So with this investigation basis we go about, I would like to touch upon a few anatomical points before we go into the proper reconstruction parts. The urethral, everyone's fear when we go for urethroplasty or any reconstruction for that matter are two questions in mind: whether it will affect the continence of the patient, and the second thing, is there any nerve injury? So I would like to address these 2 points. Regarding the incontinence, why so far there is no reported case of de novo incontinence after surgery is because the urethral sphincter is very complex. As you can see, it is composed of the external urethral sphincter, which has an inner circular layer and outer longitudinal layer, firstly. Second, this is the urethrovaginal sphincter. This one, the violet color marked one, this is the urethrovaginal sphincter, which surrounds both the urethra and vagina together. And thirdly is the compressor urethrae. The next picture you can see more clearly. So this is the sphincter urethra complex. This is the urethrovaginal sphincter, which surrounds both the urethra and vagina. And the third part is the compressor urethrae. So this kind of complex sphincter anatomy helps in preserving continence. And one more thing is, when we do urethroplasty, we cut the urethra in the midline like a straight line like this. So it, because of the multiple muscular sphincter complex which is present, it is unlikely that this single cut damages the sphincter. Apart from this, the urethra is supported by the pubourethral ligament here down like a hammock. It suspends the urethra, and here we can see the posterior wall of urethra is supported by the anterior vaginal wall and the endopelvic fascia lying on it, which is in turn supported by the arcus tendinous fascia pelvis laterally. So with this much urethral supports, a single slit-like incision in the urethra in the midline is unlikely to cause incontinence. This is theoretical and practical aspects also. From the literature available, there is no de novo incontinence reported. The second part, coming to the nerve supply. So this is the brief anatomy. This is the clitoris, vestibular bulbs, and this is the ischiocavernosus muscle just beneath the inferior pubic ramus. Now our area of interest, as you can see in this picture, is here, where I am mostly restricting my talk to dorsal onlay buccal mucosal graft. So wherein the fear of injury to the neurovascular bundle is more. So this is our area of interest. This is the urethra and this is the clitoris. So in between is our plane of dissection. So in this plane, if we dissect, the dorsal nerve of clitoris comes here, as you can see in this picture. It comes beneath the inferior pubic ramus, and on the glans, it runs on either side at 1 and 11 o'clock position and enters here at the distal tip of the glans is supplied. Whereas our incision will be here somewhere between the urethra and the clitoris. So the dorsal nerve of clitoris is unlikely to get disturbed here. That is one point. The second point is, as we come laterally in this plane, the cavernosal nerves are likely to get injured if we go more laterally. So all this can be avoided by sticking more close to the urethra on the dorsal aspect and slightly away from the clitoral neurovascular bundle. So coming to the treatment aspects, what are the available options? Let us see. The overall goal of urethral stricture is to relieve the obstruction while still maintaining continence. So what the literature describes is, from the olden days and up to current day practice, the urethral dilatation either with sounds or a VIU. The secondly is the urethroplasty, wherein there are two big options. One is the flap urethroplasty with either a vaginal wall flap or a vestibular flap. And lastly is the graft urethroplasty, wherein again we have the buccal mucosal graft, labial graft, vaginal mucosal graft. And here again there are multiple options, whether it's a dorsal or a ventral only. What literature says regarding the urethral dilatation, the success rate is around 14 to 49%. But yes, it comes with the multiple morbidity like of coming frequent hospital visits and the additional costs. And also the person has to do self-dilatation, self-intermittent catheterization on and off. So with all this, when the patients were monitored for about 3 to 6 months, the success rate is only up to 50%. So this is the literature available regarding urethral dilatation. And as we can see from the systematic review on female urethral stricture came in the EAU, the success rate is around 14 to 49% with all the studies. So if we come to the next option, if we want to cut down the hospital visits, lessen the patient morbidity, improve the symptoms, not only the obstructive symptoms, but also psychological quality of life and also the sexual function improves with urethral reconstruction is what literature says. So we have come to the option of urethroplasty nowadays. What are the options? Either flap or graft. Coming to the local flap urethroplasty, there is vaginal flap or a labial flap. The success rate described is around 83 to 100%, but the mean is lower than that described with graft urethroplasty. Coming to graft urethroplasty, that is a vaginal graft, which can be inlay or onlay vaginal graft, or a buccal mucosal graft, which is a dorsal onlay commonly performed. So what are the success rates with vaginal graft? Again, it is around 73 to 100%. And the buccal mucosal graft has reported the highest success rate among the all, that is with a mean of 94%. But one problem is the follow-up period is slightly shorter, that is 15 months average. So to date, there is no long-term follow-ups to state with a concrete evidence that one is better than the other. But with the available literature, the buccal mucosal graft urethroplasty holds the higher success rate than the other approaches. So what are our dilemmas? Whether I should put a flap or a graft, whether it's a vaginal or a buccal, whether I should go dorsally or ventrally, these are the dilemmas. So as I said earlier, the flap urethroplasties have got mean 80 to 90% success, whereas the graft urethroplasties have got a higher mean success rate around 94%. Now coming to whether a buccal or vaginal mucosa, the buccal mucosa has the advantages like it is hairless, it has an elastin-rich epithelium and multiple, that is pan-laminar vascular supply, which enables easy inosculation and imbibition and take of the graft. How to choose between dorsal or ventral, each one have their own pros and cons. The dorsal approach advantages are the graft saculations are minimal, because of the support provided by the clitoral cavernosa, and we leave the ventral part untouched for future incontinence procedures. Also, the urinary stream is not affected, and it stays away from the vagina. What are the concerns with dorsal approach? Injury to sphincter and clitoral neurovascular bundle injury, requirement of general anesthesia, and nasotracheal intubation. What about sexual function? So far, I could find this literature which said that the dorsal only urethroplasty has no effect on the sexual function. It does not negatively impact the sexual function. In fact, it is found to improve after the relief of obstruction. Now, coming to the ventral approach, what are the advantages? The urethral mobilization is minimal and it is more familiar. There are some concerns with the ventral approach as well. As I said, the angulation of the urethral meatus becomes downward, and the possibility of urethrovaginal fistula development and further anti-incontinence surgery will become challenging. Now, coming to the dorsal onlay BMG, how to harvest a buccal graft, a few points. We should choose the patients correctly, inspect the oral mucosa preoperatively before case selection, assess for any submucosal fibrosis, any history of areca nut products like betel nut chewing, etc., and the ability to open the mouth. So this kind of any infection or tobacco chewers, previous surgery, all this have to be carefully inquired and inspected, and ideal case has to be selected. Then the preoperative preparation includes chlorhexidine mouthwash, which is at least twice a day from 3 days preoperatively, and we start IV antibiotics a day before. And nasotracheal intubation has to be planned preferably. The instruments required are, so these are the instruments which are required. The Kilner-Doherty mouth retractor if available. Otherwise, the labial stitches with silk, on needle silk will do. Bipolar electrocautery. So 2% lignocaine with 1 in 1 lakh adrenaline dilution, around 10 ml. This is a marking scale, marker pen, iris scissors, 15 blade, thumb forceps, suction, and the board, wooden board to place the graft, and small needles, and these kind of gauzes which are silk tied at the end, and adrenaline soaked gauze piece as well. So coming to the technical aspects, how do we harvest the buccal graft? After such retraction, the parotid duct has to be carefully identified. As you can see on the right hand side picture, it lies opposite the second molar tooth, upper second molar. So this has to be marked, and the required graft has to be marked preoperatively, and with lignocaine adrenaline injected beneath the mucosa after about 5 minutes to 10 minutes. So this kind of 4 by 2.5 centimeters approximately, whatever the length required graft is taken, taking care not to injure the parotid duct and stay a little away from the angle of mouth, and also not to go very close to the gingival sulcus. So this is how it has to be done. The graft is harvested, and this is how the bed looks like. We generally don't do closure of the mucosa after harvest, so far whatever cases we have done, and it gives good results. The mucosa heals like this very well. This is on the post-op day 5. It has healed very well, and the patient can start taking oral diet from the next day onwards. Cold clear liquids, ice cream to be encouraged, and cold packs can be kept on the cheek. So regular diet can be taken from second post-op day. We continue chlorhexidine mouthwash for 3 days post-operatively, oral antibiotics until catheter removal. So coming to the urethroplasty per se, I will show a few pictures, and in the last I will be showing a video. So with the patient in exaggerated lithotomy position, this is how we take the stay stitches from the labia. The circummeatally, the place is marked with a marker pen from 3 o'clock to 9 o'clock position like this. And this is how we give the incision, suprameatal incision. And the plane of dissection is maintained close to the urethra in the retropubic space like this. So it has to be maintained close to the urethra in the retropubic space. And the proximal extent is assessed after adequate mobilization, we incise the urethra in the midline dorsally, and whether this incision is adequate or not, we say with a 10 Hagar's dilator or a 30 French bougie after taking stay stitches. So this is how we have incised the urethra in the midline. The length of the defect is assessed. It is measured with a scale, and that much amount of graft is taken. After taking the graft, it is prepared, defatted, meshing done, and this is how it goes and sits in the urethra. I will be showing the video shortly. This is how during quilting it looks, and the neomeatus is fashioned like this. So this is the buccal mucosal graft urethroplasty surgery we have done. So this is a patient. She is a 56-year female. She had voiding LUTS for 1 year, and she failed urethral dilatations 3 times previously. This was a uroflow and ultrasound. So it is unable to negotiate a 10 French feeding tube. 5 French feeding tube is inserted. This is how we mark suprameatally from 3 o'clock to 9 o'clock position. And from the edges of the meatus, stay stitches are taken using 40 vicryl. The incision is deepened and it is maintained close to the urethra on the dorsal aspect, staying away from the clitoris, very close to the urethra. So as we extend proximally, the urethra is incised in the midline exactly with sharp scissors, iris scissors, and from the edges again space sutures are taken using 40 vicryl. The adequacy is confirmed by placing a 20 French Foley or a 10 Hagar dilator. So once the catheter goes in freely, we ensure that there is no further narrowing proximally. We also do an intraoperative cystoscopy to confirm. And this is how the length of the defect is measured. And that appropriate length of graft is harvested. After injection of lignocaine saline, the graft appropriate size is taken, harvested. This is how it is meshed after defatting. So from the graft, suture is taken and the graft is placed and stitched with the apex of the urethral incision. Further, from the edges of the graft to the edges of the urethral mucosa, suturing is done like this. So from the center of the graft to the clitoral cavernosal bed, as you can see, quilting is done here. So this provides a good support and avoids the graft circulation, and the graft take is also better. So this is how from the edges of the graft to the edges of the urethra, suturing is done. It is continued from proximal to distal. And further quilting is again done to the clitoral cavernosal bed.
From proximal to distal.
So with this kind of fashioning of the neourethral meatus is done. After coming to the edges of the urethral mucosa, the additional graft is trimmed, and at the end, the opened incision where we have given that part, the graft edges are sutured like this, and this is how the neomeatus is fashioned. And we place usually a 20 French Foley catheter. It has gone very easily without resistance. This is the post-op picture, how it looks. This is the picture on day 3, and on day 14, this is the picture. So we usually remove the catheter on the second after 2 weeks, that is on the 14th day. So these are our follow-up results. This is the preoperative picture on the left-hand side. At the 3 weeks post-op, this is the uroflow with 29 ml per second max flow. And this is the same patient, 2 months follow-up. The flow remains good and there are no complaints, no history of any de novo incontinence. This is at 3 months post-op, and we have done postoperative cystourethroplasty in one of our patient. This is at 4 months. The video is playing a little slowly. So this is admits 22 French sheath without any resistance. So this is how it looks, the urethra. So there is no resistance. There is no need for any further auxiliary procedures, and the flow remains above 15 ml per second. So this is our follow-up protocol. We remove the catheter at 14 days. We do uroflowmetry and post-void residue at 1 month and every 3 monthly. And initial cystoscopy is done at 1 month, and after that at the end of 3 months for 1 year. So this is our criteria for success. Symptomatic improvement by the IPSS score. The uroflow remains above 12 ml per second with low PVR and able to negotiate a 14 French catheter without resistance and no further need for auxiliary procedures. So it is important to select the case very carefully, not just by the high pressure flow, because there could be a component of non-relaxation of outlet as well. An underlying neurogenic component has to be carefully ruled out in such patients. And multiple urethral surgeries or previous radiation, concomitant malignancy, so such patients to be avoided in the beginning at least. So careful case selection is important. So with our experience, I'm sharing. Of, we have done 13 cases so far of all our dorsal only buccal mucosal graft urethroplasty with indication of failed dilatation at least one time. So this is our investigative protocol. We do the Uroflow PVR, MCUG, urodynamics, and preoperative cystoscopy. The mean patient age was 48.3 years. The success rate is 11 out of 13 patients have succeeded, are successful. 84.7% is the success rate. The mean follow-up is 18.2 months. The reasons for failure in the two patients are: one patient had lichen sclerosis, so the disease has recurred, and the other patient had underactive bladder, it's a diabetic patient. The patient is on CIC now. There is no incontinence de novo reported. So to conclude, consider urethroplasty for failed dilatation more than one time. Early reconstruction is better. Appropriate case selection is important, and surgeon experience and familiarity also matters. The trends are changing and we need to change. So thank you so much for the opportunity.
Thank you, Soundarya, for the excellent talk. And I will stop the. Yeah. So there are first a couple of questions from the audience. I like to ask them, how do you do vesicocystourethrogram in female if you are unable to pass feeding tube also? Neeraj Agarwal.
So we do an ultrasound guided puncture of the bladder. So with the needle, we fill the from the suprapubic site, we fill the bladder with a contrast, and then we ask the patients to void.
I have a
Otherwise,
doubt that without any diagnosis like MCUG, you can dilate also if the ultrasound is normal, and later on follow up you can do second time when you are getting stenosis or decreased stream.
yes, sir, we
So
don't do initially on the first visit, we do not do.
yeah, yeah. So
We do
according
only
to that,
ultrasound uroflow,
yeah.
and then based on that, we do dilatation. And once the dilatation, initial 1 or 2 times dilatation fails, and the patient gets frequent recurrence of symptoms, like within 2 weeks, they report recurrent symptoms, and we investigate further.
That's why very few patients. That is a theoretical question by Neeraj. That it is okay, good question, but you can do suprapubical ultrasound guided. That's not a problem. But the thing is, if they cannot void after injecting contrast, it may cause infection. We have to keep in mind. Uh, but my question in the other way around is, when you do first dilatation, when your patient comes in retention, usually SPC in females we rarely do.
Yes, sir.
In the first go, when the retention is there, if feeding tube of 5 French could not be passed by staff nurse, and if you take into the theater, what instrument or scope do you find? We have done, you might have remembered, we have done couple of times that which instrument, particularly I'm giving hint that scope goes, say,
Uretros
yeah,
four
ureteroscope
four
or 4 by 6.5
4 by
ureteroscope.
6.5 ureteroscope or a 7.5 French nephroscope.
Yeah,
With that scope,
7.5
we pass
French
guide wire
with guide wire,
and
7.5 French directly before you pass the agar dilator, which may cause severe
false
damage.
passage. If we
Yeah,
initially do with the smallest dilator, it will go into the false passage.
yeah.
So when we suspect such critical narrowing, we generally go with the smallest nephroscope, that is 7.5 French or 4 by 6.5 French ureteroscope. We pass the
Under
guide wire,
yeah, yeah.
and over the guide wire we do the Teflon dilatation which goes over the guide wire, the
In
one we
fact,
use for
in
ureter.
fact, you can give one more information. If the guide wire over the guide wire, there are occasions where we used Soundarya must tell, like in PCNL, we have used alkane dilator also. Severe narrowing, that's
Yes, sir.
what Neeraj is saying. We passed alkane dilator over that slowly up to 12 French. We have passed the dilator and then inspected with nephroscope. So with our experience, because pretty every urologist who has busy practice will get meatal stenosis, I feel already it is a bad disease. Like in male, female also, if you damage the mucosa, you are adding more insult. So use ureteroscope or nephroscope or a fine guide wire and confirm. Then do dilatation systematically under vision with the scope. After that, sequential dilatations carefully. That is one question. Second question Srinivas G is asking is any role of alpha blockers in urethral stricture disease of females? Any literature, Soundarya?
So far, no literature supports the use of alpha blocker, sir. And after using, there is no improvement of symptoms if stricture is present. If the anatomical narrowing is present, then there is no role for alpha blocker. We have seen practically also, and there is no literature support available.
Many times I have also used, they will come back. They rarely get a very good result like in men. Definitely, the
Yes.
bladder neck spasm, bladder neck contraction, physiological contraction, or spasm. I have not seen patients saying that I am really happy, I don't have any problem.
Yes, sir.
Soundarya, I wanted to ask you first, dilatation findings. Are they important in deciding the future morbidity and course? Like a patient who presents with a very small narrow submeatal, or a patient is average. Sometimes narrowing will not be much. Then you look into the other causes. Do you think that first findings of the dilatation and cystourethroplasty are important documentation?
Yes, sir. It is very important documentation. If the narrowing is very critical, then it is more likely the patients will come back very early with early recurrence of symptoms. And also, they cannot go along with the multiple dilatations. They will require graft reconstruction at the earliest. So, better to go for early reconstruction to avoid more fibrosis and multiple dilatations.
Do you think that the latest papers, the incidence of using buccal mucosa or flap or any form of reconstruction in female is increasing in last 1 decade? For example, if you say RIRS, all Western countries have shifted to RIRS. Are you seeing any change? Because even now, out of 5 patients, we do 4 dilatation. We tell them they will be hesitant, and any surgery reconstructive, there are certain recurrences like that. Do you
Yes,
think
sir.
that the literature is changing and people are attempting in the worldwide?
Yes, sir. Over the last 15 years, the papers have increased in the more of reconstruction of the urethral stricture, and papers on urethral dilatation are less. And even up to date, there are more and more people who are attempting flap or graft urethroplasty. More of graft urethroplasty papers are more. The only thing is the follow up is short term. Otherwise, there are many people who have started attempting. Previously, we used to hear only dilatation or OT urethrotomy, but I think many people are confidently attempting urethroplasties, and we are seeing more in the conferences and AUA meetings. Such literature as support has definitely increased more. And so with this evidence, people are have started attempting more. That is very true.
See, one very, very important question everybody is asking is, when you cut it, there are some problems. I want to ask you clearly that
Yes.
first thing is, if you force the Foley's catheter, it may go after cutting few centimeters. Why don't you cut in all cases up to bladder neck is my first question. Number two, why do, if the bladder neck is cut, do they get incontinence theoretically? There are papers, you know better. And three, the length of the incision, is there any other means you consider, like cystoscopy finding while coming back, distensibility of the urethra with a small scope? What is your guideline which helps you to cut the length? This is a common question, because one thing everybody is afraid is incontinence.
Yes, sir.
Majority of the articles are saying that incontinence will not happen because it is a clean cut of a sphincter or a rubber. If you cut a thick rubber one cut, the rubber will not loosen up.
Yes, sir.
Length of the cut is a controversy.
Yes, sir.
By
So the
the
most
current approach,
common
yeah, yeah,
location of the stricture is either mid urethra or distal urethra. So we need not cut the bladder neck in all cases, sir.
okay,
So, and the preoperative assessment with the urethroscopy, the resistive urethroscopy, will give us an idea about the proximal extent of the stricture. So, if the urethral mucosa is elastic, distensible, and as we have seen in the previous picture, if that white fixed narrowing, which is not admitting, or unhealthy mucosa, which is whitish in color, gray color, such kind of lichen sclerosis, if that area is not there, then that means we have crossed the area of site of stricture. So we need not cut the bladder neck in all cases. And even if we cut the bladder neck, the literature says that there is no incontinence reported. And so there are two things to assess the site and length. One is the preoperative MCUT, where we see the pre-stenotic dilatation and the distal side of the stricture. And the second is preoperative cystourethroplasty. We can also confirm on table after we cut inside the urethra and midline. We can put a scope and see whether proximal to that the urethra is healthy or not. We can visually inspect as well. So in
okay.
all cases, bladder neck is not mandatory.
I understand. If the same question I have to ask on the ventral onlay, if you are going on cutting, you can go cut up to bladder also, isn't it?
Yes, bladder can be
See,
cut.
bladder also can be cut. So,
Yes.
are there any reports that a long length strictures are repaired buccal mucosa ventral onlay? No,
Long length strictures, not
I mean, uh,
not much, sir. Like only distal and mid urethral strictures, there are reports, but long segment stricture reported ventrally.
how much literature is favoring ventral? I mean, how many papers are on ventral? How many papers are on dorsal? Is the dorsal onlay papers are more?
Dorsal papers are more, sir. Definitely more. Ventral only few are there because of the common fear of the urethrovaginal fistula. Then the urinary stream is getting splayed, and further incontinence procedures will be disturbed. The plane gets disturbed. So
Yeah.
because of this fear, people don't commonly attend. And actually, the
Ventral,
papers,
ventral also you will cut in the midline clean cut one,
yes, sir. Ventral only in the midline, clean cut,
clean cut
uh, just below above the vagina,
above the vagina.
anterior to the vagina.
Anterior to the vagina. Now coming to the important part, that is investigation. In the first 2-3 cases we have not done MCUG. Do you think that better to do MCUG in all cases before you attempt a buccal mucosal urethroplasty in female?
Yes, sir. It will be easy to explain to the patient, and we can also assess the bladder capacity and the length. And the patient to explain to the patient and to convince them to make them understand it will be useful. And it is a
What
documentation.
is the position? Do you have, do you do MCUG yourself or tell your technician who is senior, or
I do MCUG myself, sir.
any position? For example, female in a first of all, lying down in a straight position and voiding is difficult and x-ray will not show it. Do you turn 15 degrees like in men? How do they be reassured? How voiding film is taken? Is it better to be done under CM, or plain normal x-ray is enough? You can do it.
Normal X-ray is enough, sir. If the patient is very apprehensive, then it can be done in theater under CM. But usually I go and do personally, and most of them are able to void. We do under lying down position only. We take the voiding film with the normal X-ray. So
So
because
instead
I,
of
along with the female staff nurse, I accompanied, so to reassure them and give them a comfortable environment. And on the lying down position only, we take the X-ray film, voiding film.
there is no need to tilt 45 degrees like that.
No need for any tilt, sir.
To
Straight
prevent
supine.
that bladder neck distension and bladder neck opening up
Yes, sir.
like that.
Yes, it's coming, sir. Yes.
Yeah. Yeah. So, what is the role of uh, what is the role of urodynamic study? Literature says what and what you are practicing. Literature says is it recommended in all cases in buccal mucosa?
Yes,
Uh,
sir. It is recommended in all cases
why?
because we go for invasive surgery. So it's once in lifetime procedure. So the patient has to understand, and medico legally we have to be protected, and we have to rule out other causes like whether it is a non-relaxation of the outlet. The sphincter can be non-relaxing. So like for example, in an axon disease of the motor neuron disease, where we get sphincter dyssynergia or the pelvic urethral sphincter itself fails to open, but there is no anatomical narrowing. So this kind of evidence can be obtained. Another thing is to assess the compliance. So it is important to assess preoperatively because even if we just stop with repairing the urethra and the lumen is good, if the compliance is poor, then the patient will still have chances of upper tract deterioration. So that has to be ensured, and the patient has to be advised CIC. So to assess the compliance and the bladder capacity, and to rule out any other incontinence like stress incontinence or detrus or overactivity incontinence, it is important. And all the literature which has come out so far, I have seen, and everybody is doing urodynamic study in all their cases reported, and they have their criteria to assess the bladder contractility index. They have that nomogram. So if that period at Qmax is very high, then they go about with the reconstruction.
Do you in the technical point I'm asking, when you incise, normally in men there will be 120 to 140 degrees acute angulation behind the pubic symphysis. The urethra enters because of the prostate, long urethra, and then into the bladder.
Yes,
In
sir.
females it may not be that much angle.
Yes,
When
sir.
you are dissecting the urethra and taking the stay stitches and pulling,
Yes, sir.
have you gone easily to the proximal extent 4 to 5 centimeters, or should we use any specific headlight or any small projection light doing that? Or
It is.
the whatever normal lights are sufficient to see properly? Is there any landmark where we are reaching bladder neck? Can we identify something like that?
Yes, sir. We'll be able to feel the inferior pubic ramus as we go on the dorsal aspect of the urethra. So if that small headlight camera is on, it'll be better visualization will be there, definitely added advantage. So as we go on the dorsal surface of urethra, as we go about 3 to 4 centimeter more proximally, we'll be able to feel the inferior pubic ramus, and if we insert the Foley, that bulb can also be felt.
Yeah, with finger you can feel the bulb behind
Yes, sir.
the when you pull the edges, you can feel the bulb where it is coming, so that you will stop nearly there.
Yes, sir.
Yeah,
Yes.
and when you put a graft, you have shown a square type of graft. Do you have to make inverted V to fit into the angle, or not necessary? What do you think? That a little bit of tapering is required or not?
Yes, sir.
Yes.
We don't keep the, we have to keep the edge of the buccal graft from to the apex of the urethra. We don't have to make a inverted V type. We need not cut the graft on the board itself, but we can take one edge of the graft and we can suture it there. Accordingly, the length has to be adjusted, and the overhanging edge has to be tapered. That's all. There is no V-shaped trimming of the graft on the board. We need not do.
Okay. So you try to keep as breadth as possible at the proximal also.
Yes, sir.
If it is too much only, then you
Too much is also not advisable, sir, because of overhanging. So just adequate breadth will do
will
actually.
do. And what should be the adequate breadth? Do you think that millimeters? You have any idea? 1 centimeter is sufficient, or 2 centimeter? How much?
Approximately 1 centimeter, sir.
Okay. So you don't require a big graft in female, isn't it?
Not a big graft, sir. Most of the grafts we have taken are around just 2 to 2.5 centimeters defects.
Length.
At the
You are
maximum, yes, sir, length. At the
maximum
maximum 4 centimeters
4
we can.
centimeter by 1.2 centimeters.
Yes, sir, 4 by
So that
2.5
this
centimeters.
can be done easily under local. So that the reason why I am asking is
Anesthesia.
this is a common disease. One thing I
Yes,
want to tell. And low spinal anesthesia is the available everywhere. And there are no big instrument. Any surgeon who is very good surgeon in open and can take the buccal mucosa can attempt it. The worst thing that can happen is stenosis again. So can it be attempted? Is it surgically easily reproducible? In your 12 cases, do you feel initially maybe one or two cases Ramakrishna might have done, after that you have done it? Did you find any difficulty technically, or can it be reproducible? Because we all have
it
fear
can be
that
reproducible.
reproducible. So local
It can be
anesthesia,
easily reproducible.
you can take the local anesthesia buccal graft only 4 centimeter by 1.2 and then put directly incise. Only thing is thick amount of the urethra has to be dissected.
The lot of bleeding and oozing will be there, sir, once we take the graft, even though we inject adrenaline with lignocaine. So on the safer side, better to go for nasotracheal intubation, not just casually attempt with local anesthesia as my
Okay.
feel.
While doing the procedure at the urethroplasty region, do you think that bleeding will be too much, or if you are in a good plane, just outside urethra, there will be a areolar tissue, good plane will be there normally?
In initial 2-3 cuts, the bleeding will be more, sir, but later on it will stop automatically. Nothing much to fear. As we
As you go
dissect
more
the graft
proximal to
and
the,
that much time take.
do
Yes,
you
sir.
put
One in the initial incision. In the initial incision time, it will bleed, but after, as we go dissecting proximally, the bleeding will not be that much to hinder the
do
vision.
you keep while dissecting urethra any instrument, feeding tube or Foley's in the urethra, or you don't keep generally anything?
We keep initially we'll keep a feeding tube, sir. After incising the urethra, we keep a 10 French 10 Hagar number 10 Hagar dilator or a 20 French Foley catheter after incising urethra. So with that, with that support on the dilator, we keep our extending our dissection more proximally.
That helps you in dissecting the urethra.
Yes, sir. It stabilizes the urethra, so enables dissection on completely, like from 3
Generally,
o'clock to 9 o'clock position.
how many stay stitches you take to pull? First at the entrance, so you take one. Second level, usually by
First at the apex.
for the entrance.
First one at the apex. Yes.
Okay,
Before incising or before dissecting, we start one at the 3 o'clock and 9 o'clock position, sir,
okay,
of the original meatus which is present.
okay.
Then after we cut the urethra in the midline dorsally, one at the apex of the apex point and 2 on the sides. So it will
Sides.
be around 5 stay stitches.
5 stay stitches. And what is the suture you use for the buccal mucosa to the urethral mucosa, and what is the suture you use for
Urethral
printing?
mucosa. 40.
All
40. All
vicryl.
are 40 vicryl, sir.
Are all 40 vicryl.
40
Uh,
vicryl.
uh, what size Foley's catheter you keep at the end? Small like in male, or you put a bigger one so that it will other to the this thing? What is
Bigger one.
bigger one?
Yes, sir. We put a bigger one. We put a 20 French Foley catheter, and we put some liquid paraffin gauze around, and we plaster the catheter over the abdomen so that it stabilizes the graft for some time.
Yeah. And
At the end of 5 days, the patient will be.
what is the recommendation of Foley's catheter removal? Literature says, and what are you following? Literature says in whatever the
Literature
article.
says around 1 week, that is 7 to 10 days, they remove catheter. We to be on the safer side, we keep for 14 days. After at the end of 14 days, we remove catheter.
In these 12 cases, is there any case where they are coming for dilatation again?
Yes, sir. First, one patient is coming. Another patient is on CIC. One patient is coming for dilatation.
Do you have any problem in dilatation, or it's like any other case?
It's not that much critical narrowing as there was present previously, that is before to the surgery. There is only a mild narrowing, but the patient has symptoms. It is symptomatically bothersome. So we do dilatation. Once in 3 months, they come for follow-up.
So in no patient the entire graft necrosis and blackening has happened at fourth day, fifth day.
No, sir.
No.
No patient had such graft
Usually, I
necrosis.
think buccal mucosa does not get lost like that. I think
Yes, sir. The
unless
graft take is good because of the much better vascular supply in
yeah.
all the layers of the mucosa.
Primary this quilting is with the base is cavernosal bodies or the retropubic tissue.
The cavernosal bed, clitoral cavernosal bed, sir.
Yeah, that is very rich and vascular. Do
Yes,
you
sir.
have
Rich and vascular.
experience or the literature saying post radiotherapy, urethral stricture, anything? Any literature available or
Post radiotherapy stricture, I'm not aware, sir, but for our patient, practically we are not attempting.
we have not done the cases? So, if you are given choice, for example, you see if 10 OPD and all of them undergone 2 times dilatation, will you tell all the people try once buccal mucosa confidently now, or you wanted to wait for some more time? Which type are younger patients, middle age, or older patients, postmenopausal? Where you think where you will be very happy to tell buccal mucosa in first go, or critical narrowing? You know by this time of
Where most critical narrowing and where the even the smallest scope is not admitted. So such critical narrowing, especially nowadays, I'm seeing more young patients like in their 30s presenting with such critical narrowing where we have with the scope only we were able to pass the guide wire also. So such young patients where the quality of life will improve. I'll be very happy if they are agreeing to go for urethroplasty. Young patients more.
So, with this total 200 viewers are there, you have answered very well. You are in the early part of this career. Take up this seriously. Lot of patients are there. I think we have not seen any severe morbidity with this procedure. As you all know, buccal mucosal graft is not a very like in male urethral stricture. It is used by everybody now. OIU incidence is decreased. Hope if people like you take up it seriously and follow up it seriously, and maybe report your early series in publication, it will be nice. So I wish you to concentrate on this subject and wish you all the best. Thank
Thank
you
you.
very much for nice presentation and nice answering. Thank you.
Thank you for the opportunity, sir.
Thank you. We'll close the meetings on